Hello, future nurses and NCLEX achievers. Welcome back to Stancoast NCLEX, your go-to destination for mastering every nursing concept with clarity and confidence. Here, we post 2 to 3 advanced NCLEX videos every single day, filled with high-yield rationales, clinical insights, and Stancoast pearls that make complex topics easy to remember and apply. In today's respiratory-focused session, we are tackling one of the most important and frequently tested conditions: asthma. Asthma is a chronic inflammatory disorder of the airways that requires quick recognition, effective intervention, and skilled client education. In this lesson, we will review the pathophysiology behind bronchospasm and airway hyperreactivity, identify early and late warning signs, and discuss key nursing priorities during both acute and long-term management. You will learn about bronchodilator and corticosteroid use, oxygen therapy, peak flow monitoring, and trigger prevention, all explained with practical reasoning and NCLEX-ready clarity. So, stay with us till the very end, because this session will help you connect pathophysiology to practice, one breath at a time. And remember, at Stancoast NCLEX, we do not just teach for exams, we prepare you to breathe confidence into your nursing career. Let's begin today's vital session on nursing care of clients with asthma. Before we dive into today's lesson, let me take a moment to guide you towards something truly valuable.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us transition into this NCLEX-style scenario that focuses on a critical respiratory emergency and the nurse's immediate action to optimize oxygenation. A 32-year-old client with a long history of bronchial asthma is admitted to the emergency department in severe respiratory distress. The client is visibly struggling to breathe, using accessory muscles, producing audible wheezes, and unable to complete full sentences. While preparing to auscultate the client's lung sounds and evaluate the extent of airflow obstruction, the nurse must determine the best position to assist the client to promote optimal respiratory effort and allow for accurate assessment. Now, let us carefully review the available options. Option A suggests placing the client in a sitting upright high Fowler's position. Option B recommends having the client stand beside the bed. Option C involves positioning the client lying flat in the supine position, while Option D proposes lying on one side in the lateral recumbent position. The correct answer is Option A, sitting upright in a high Fowler's position. Moving forward to the detailed rationale, bronchial asthma involves airway inflammation, mucosal edema, and smooth muscle constriction, leading to bronchospasm and airflow obstruction. During an acute attack, the client's respiratory muscles are overworked, and oxygen demand increases significantly. Therefore, positioning becomes one of the most immediate and effective non-pharmacological nursing interventions. The high Fowler's position allows the diaphragm to move downward freely, maximizes lung expansion, and permits the accessory muscles, such as the sternocleidomastoid and scalene, to function efficiently. Moreover, it enhances oxygen exchange by improving alveolar ventilation and makes it easier for the nurse to auscultate the anterior, lateral, and posterior chest fields for wheezes, raunchy, or diminished breath sounds. This position also encourages gravitational drainage of secretions, reduces air trapping, and alleviates the client's sensation of air hunger, all of which collectively enhance comfort and assessment accuracy. On the other hand, Option B, standing beside the bed, may initially appear to promote chest expansion, but it is not sustainable for a client in respiratory distress. Standing increases fatigue, oxygen consumption, and risk of syncope due to hypoxemia. In acute asthma, safety and energy conservation are critical, making standing an unsuitable choice. Meanwhile, Option C, lying flat in the supine position, is highly contraindicated during respiratory compromise. Supine positioning restricts diaphragmatic excursion, compresses lung tissue, and heightens intra-abdominal pressure, worsening ventilation perfusion mismatch and hypoxia. In clients with asthma, this position can intensify dyspnea and should always be avoided. Lastly, option D, lying on one side in the lateral recumbent position, may assist in postural drainage or unilateral lung expansion under certain therapeutic settings, but not during acute respiratory distress. This position limits full chest expansion and creates uneven ventilation, which can further exacerbate hypoxemia. Transitioning to our Stancoast clinical insight, remember this key principle. Position is therapy. In asthma, gravity becomes your ally. Upright posture frees the diaphragm, expands alveoli, and transforms every breath from struggle to strength. And to conclude with a Stancoast high-yield NCLEX pearl, always position clients in respiratory distress in the high Fowler's position to maximize lung expansion and ease the work of breathing. Avoid flat or dependent positions that restrict ventilation, assess breath sounds systematically from anterior to posterior, and support the elbows on pillows or a bedside table to reduce fatigue of accessory muscles. Let us transition into this next high-yield NCLEX-style question that sharpens both your clinical reasoning and understanding of respiratory monitoring. A nurse is assessing a client admitted with an acute asthma exacerbation and plans to monitor the client's oxygenation status using pulse oximetry. To obtain the most accurate and reliable reading, where should the nurse place the pulse oximeter sensor? Here are the available options to consider carefully. Option A, on the client's finger. Option B, on the client's palm. Option C, on the client's earlobe. Option D, around the client's leg. After thoughtful evaluation, the correct answer is option A, on the client's finger. Now, let us explore the expanded rationale behind this correct choice. Pulse oximetry is a non-invasive monitoring technique that measures arterial oxygen saturation, SpO2, by transmitting two wavelengths of light, red and infrared, through pulsatile capillary blood. The ratio of oxygenated to deoxygenated hemoglobin determines the reading. The finger, particularly the index, middle, or ring finger, is the most reliable and widely used site because it has thin tissue and abundant capillary beds that allow optimal light passage and accurate signal detection. In a client experiencing an asthma attack, continuous oxygenation assessment is crucial since airway inflammation, bronchospasm, and mucus plugging can create ventilation perfusion mismatch and lead to hypoxemia. By ensuring accurate SpO2 readings, the nurse can effectively titrate oxygen therapy and evaluate the response to interventions such as bronchodilators and corticosteroids. Before applying the probe, the nurse should remove nail polish or artificial nails, as they can interfere with light transmission, and ensure the extremity is warm to avoid false low readings due to vasoconstriction. Meanwhile, it is important to understand why the other options are less effective. To begin with, option C, on the client's earlobe, may be used as an alternative when finger perfusion is compromised. For instance, in cases of shock, hypothermia, or peripheral vascular disease, because earlobes retain better circulation under low perfusion conditions. However, it is not the first choice for clients with adequate hand perfusion. Moving to option B, on the client's palm, this site is not recommended since the palm has thicker tissue layers that block light transmission and make it difficult for the sensor to detect arterial pulsations accurately. Finally, option D, around the client's leg is inappropriate because leg musculature is dense and lacks sufficient capillary pulsation and tissue transparency for effective signal detection, leading to erroneous readings. Transitioning now to the Stancoast clinical insight, remember this essential nursing truth. When oxygenation matters most, the pulse oximeter becomes the nurse's window into the lungs. A properly positioned sensor can distinguish between a stable airway and one heading toward respiratory failure. Accuracy begins with the right site. Moving on to the Stancoast high-yield NCLEX pearl, keep these vital points in mind. Pulse oximetry measures SpO2, not arterial oxygen pressure PaO2. Always ensure extremities are warm and nail polish is removed before applying the sensor. If peripheral perfusion is poor, switch to the earlobe or forehead probe. Most importantly, correlate the pulse oximetry reading with your clinical assessment and arterial blood gas analysis whenever indicated. Persistent SpO2 levels below 90%, during an asthma attack signal impending respiratory compromise, initiate oxygen therapy promptly, and reassess immediately. Let us continue this engaging NCLEX-style journey with another clinically relevant question that reinforces your understanding of oxygenation assessment. A nurse is evaluating the oxygenation status of a postoperative client who is receiving supplemental oxygen via nasal cannula. The pulse oximeter shows a reading of 96%, and the arterial blood gas report indicates a partial pressure of oxygen of 85 millimeters of mercury. Considering these findings, which interpretation by the nurse most accurately reflects the client's tissue oxygenation status? Here are the options to consider carefully. Option A, the client is hypoxemic and requires immediate intubation. Option B, the client's oxygenation is within the normal range. Option C, the client is experiencing mild respiratory acidosis. Option D, the client requires an increase in oxygen flow rate. The correct answer is option B. The client's oxygenation is within the normal range. Now let us explore the expanded advanced rationale behind this interpretation. A pulse oximetry reading between 95 and 100% indicates normal arterial oxygen saturation, suggesting that hemoglobin molecules are adequately saturated with oxygen and effectively transporting it to the tissues. Likewise, a partial pressure of oxygen between 80 and 100 millimeters of mercury obtained from an arterial blood gas analysis reflects normal plasma oxygen tension. These two parameters align closely on the oxygen-hemoglobin dissociation curve, where an oxygen saturation above 90% corresponds to a partial pressure greater than 60 millimeters of mercury, sufficient for cellular oxygen delivery and metabolic needs. Moving forward, it is essential to recall that pulse oximetry is a non-invasive and continuous monitoring tool that measures the proportion of oxygenated hemoglobin by transmitting red and infrared light through pulsatile capillary blood. However, certain factors can interfere with accuracy, such as movement, nail polish, hypothermia, anemia, poor perfusion, or carbon monoxide exposure. Therefore, the nurse should always interpret readings in conjunction with arterial blood gas values and clinical presentation. In this case, both the oxygen saturation and the arterial oxygen tension fall within normal ranges, confirming adequate oxygenation without the need for immediate intervention beyond continued monitoring. Turning to the incorrect options, option A, suggesting that the client is hypoxemic and needs intubation, is incorrect because hypoxemia is defined by a partial pressure of oxygen below 60 millimeters of mercury or an oxygen saturation below 90%. Since this client's results are well within normal limits, invasive airway management is unnecessary. Next, option C, which claims the client is experiencing mild respiratory acidosis, is also incorrect. Respiratory acidosis involves elevated carbon dioxide levels and decreased blood pH, not normal oxygenation values. There is no evidence of carbon dioxide retention or acid-base disturbance in this scenario. Finally, option D, proposing an increase in oxygen flow rate, is likewise incorrect. Oxygen flow should only be increased if oxygen saturation persistently drops below 90% or the client exhibits symptoms of hypoxia, such as cyanosis, confusion, or tachypnea. Administering excess oxygen without indication can lead to oxygen toxicity, particularly in clients with chronic obstructive pulmonary disease. Transitioning to our clinical reflection, Stancoast Clinical Insight. Pulse oximetry tells the story of oxygen delivery, but arterial blood gases reveal the depth of that story. True nursing expertise lies in correlating both values instead of reacting to one in isolation. And now, moving on to the key takeaway, Stancoast High-Yield NCLEX Pearl. Normal oxygen saturation ranges between 95 and 100%. Normal partial pressure of oxygen is 80 to 100 millimeters of mercury. Initiate oxygen therapy when oxygen saturation falls below 90% or partial pressure drops below 60 millimeters of mercury. Always verify probe placement and peripheral perfusion before responding to low readings. Remember, oxygen saturation reflects oxygenation, not ventilation. Use arterial blood gases to assess carbon dioxide levels and acid-base balance. Let me share something before we jump in.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us move smoothly into this next clinically rich NCLEX-style question that blends pharmacology and respiratory nursing care. A nurse is evaluating a client with acute asthma who continues to experience shortness of breath despite receiving the prescribed therapy. The physician has just ordered a nebulized dose of levobuterol hydrochloride, also known as Xopenex. After administration, the nurse must determine which finding represents a common and expected side effect of this medication. Now, here are the possible options to consider carefully. Option A, a respiratory rate of 28 breaths per minute. Option B, a heart rate of 96 beats per minute. Option C, a blood pressure of 100/60 millimeters of mercury. And option D, drowsiness. The correct answer is option B, a heart rate of 96 beats per minute. Moving ahead to the detailed explanation, levobuterol hydrochloride, commonly known by its brand name Xopenex, is a selective beta-2 adrenergic agonist widely used to manage bronchospasm in asthma and chronic obstructive pulmonary disease. It works by stimulating beta-2 receptors located in the bronchial smooth muscle, which promotes relaxation and dilation of the airways, thereby relieving wheezing, dyspnea, and airway obstruction. However, a small portion of the drug may also activate beta-1 receptors found in the heart, leading to a mild and transient increase in heart rate or palpitations. Thus, a heart rate of 96 beats per minute following therapy is a predictable and harmless side effect caused by mild sympathetic stimulation. Furthermore, it is important for the nurse to continuously monitor for excessive tachycardia, anything above 120 beats per minute, or for any irregular rhythm, which could indicate an adverse response rather than a normal pharmacologic effect. In clients with underlying cardiac disease, hypertension, or hyperthyroidism, this mild increase in pulse should still be observed closely to ensure cardiovascular stability throughout treatment. In contrast, a respiratory rate of 28 breaths per minute, as in option A, reflects ongoing respiratory distress rather than a side effect of the medication. It implies that the asthma attack has not fully resolved and may require further bronchodilator therapy or additional interventions. Option C, a blood pressure of 100/60 millimeters of mercury, lies within the normal range and is not related to the bronchodilator's mechanism of action. Option D, drowsiness, is also incorrect because levobuterol typically causes stimulation symptoms such as restlessness, tremor, and nervousness rather than sedation, due to its sympathomimetic properties. Transitioning now to a deeper insight, let us explore the Stancoast clinical insight. Levobuterol opens the airways, but also wakes up the heart. A vigilant nurse monitors not only the ease of breathing, but the rhythm of the pulse, ensuring bronchodilation never becomes tachycardia. And finally, here comes your Stancoast high-yield NCLEX Pearl. Mechanism: selective beta-2 agonist leading to bronchodilation. Therapeutic goal: improved airflow and reduced wheezing. Common side effects: tachycardia, tremor, nervousness, and headache. Priority monitoring: always check heart rate, rhythm, and oxygen saturation after each nebulization. Client teaching: instruct clients to report chest pain or palpitations and avoid overuse, since excessive use may paradoxically worsen bronchospasm or strain the heart. In summary, recognizing that a mild increase in heart rate after levobuterol administration is both expected and physiologically explained helps the nurse differentiate between a therapeutic response and an adverse effect, an essential distinction for safe and effective respiratory nursing care. Let us transition into this next critical NCLEX-style scenario that highlights the nurse's responsibility for post-procedure safety and complication prevention. A nurse is supervising a licensed practical nurse who has just assisted a laboratory technician in obtaining an arterial blood sample from a client's radial artery for arterial blood gas analysis. Now the question arises: immediately after the specimen is drawn, Which nursing action should the licensed practical nurse perform to prevent a serious complication at the puncture site? Here are the options to consider carefully. Option A. Apply direct pressure to the puncture site for at least 5 minutes. Option B. Warm the blood sample in the specimen tube for 5 minutes. Option C. Assess the client's blood pressure in 5 minutes. Option D. Elevate the client's arm above heart level for at least 5 minutes. The correct answer is Option A. Apply direct pressure to the puncture site for at least 5 minutes. Now, let us move thoughtfully into the rationale behind this essential action. Applying firm, direct pressure over the radial artery puncture site for a minimum of 5 minutes, and for at least 10 minutes in clients receiving anticoagulant therapy, is a crucial step after arterial blood gas collection. Because the radial artery carries oxygenated blood under high pressure, inadequate compression can result in continuous bleeding, hematoma formation, arterial spasm, or even thrombosis, which could compromise hand circulation. Maintaining direct pressure allows time for platelet aggregation and clot formation, ensuring hemostasis and preventing tissue injury. Before any arterial puncture, nurses should always perform the Allen's test to confirm adequate collateral circulation between the radial and ulnar arteries. If this test is negative, puncturing the radial artery may lead to ischemia of the hand. After obtaining the specimen, it must be immediately placed in an ice slurry to preserve the accuracy of oxygen, carbon dioxide, and pH levels by slowing down metabolic changes. Prompt transport of the specimen to the laboratory is essential for reliable results. Neglecting to apply sufficient pressure can lead to painful hematoma, nerve compression, or even compartment syndrome in severe cases. Therefore, continuous monitoring for signs of distal ischemia, such as pallor, delayed capillary refill, or absent pulses is imperative, and any abnormalities should be reported without delay. As we now review the incorrect choices, it becomes evident why they are inappropriate in this clinical setting. Option B, warming the blood sample, is incorrect because arterial blood specimens must be kept cold, not warm. Warming allows ongoing cellular metabolism that can alter gas levels and distort test accuracy. Option C, assessing blood pressure after 5 minutes, is irrelevant to the immediate concern because the minimal blood volume withdrawn does not influence systemic pressure. The focus should instead remain on maintaining site safety and hemostasis. Option D, elevating the arm for 5 minutes, is a technique suited for venipuncture, not arterial puncture. Because arterial pressure is higher, elevation alone cannot stop bleeding effectively and may even hinder clot formation. Firm, sustained pressure remains the only effective intervention for preventing post-arterial complications. Transitioning to professional insight, here comes the Stancoast clinical insight. When the artery is punctured, the clock starts ticking. 5 minutes of firm pressure can prevent 5 days of pain. The nurse's hands become the shield protecting against hematoma and ischemia. Finally, wrapping up with the Stancoast high-yield NCLEX Pearl. Always perform the Allen's test before radial arterial sampling. Apply firm pressure for at least 5 minutes. 10 if the client is anticoagulated. Immediately place the sample on ice after collection, never elevate or massage the site, and continuously monitor for complications such as hematoma, arterial spasm, or loss of distal pulse. Let us now transition into an important respiratory scenario that highlights both equipment monitoring and clinical judgment in oxygen therapy. A client experiencing an acute asthma exacerbation is currently receiving oxygen at 60% through a partial rebreathing mask with an attached reservoir bag. While carefully observing the setup, the nurse notices that the reservoir bag completely deflates every time the client inhales. At this critical moment, the question arises: what should the nurse do next to ensure the client's safety? Moving on to the options. Option A, document the finding as expected with this oxygen delivery system. Option B, notify the respiratory therapy department immediately. Option C, loosen the mask straps to allow more air entry. Option D, drain the condensation and reapply the mask. The correct answer is Option B, notify the respiratory therapy department immediately. Now, let us delve into the expanded advanced rationale behind this essential decision. A partial rebreathing mask is designed to deliver oxygen concentrations of approximately 40 to 70% by allowing the client to rebreathe part of the exhaled gases that still contain oxygen stored in the reservoir bag. For this system to work properly, the bag must remain partially inflated, ideally 1/3 to 1/2 full, throughout inspiration. This ensures that the client receives the intended oxygen concentration while preventing excessive rebreathing of carbon dioxide. However, if the bag collapses completely during inspiration, it indicates that the oxygen flow rate is too low to meet the client's demand. This insufficiency can quickly result in hypoxemia and carbon dioxide retention, conditions that can be life-threatening during an asthma attack. Therefore, the nurse must report this observation immediately to the respiratory therapy department so the flow rate can be adjusted or the equipment replaced. Let us now analyze the incorrect options. To begin, option A is incorrect because a completely deflated bag is never normal. It signals improper oxygen flow, not expected function. Next, option C is incorrect since loosening the mask would break the seal, reducing the fraction of inspired oxygen and worsening hypoxia. Lastly, option D is incorrect because moisture accumulation is a common effect of humidified oxygen and can simply be wiped off without disrupting therapy. It does not require urgent reporting. Now, transitioning smoothly into the deeper clinical wisdom behind this concept. Transitioning into the Stancoast clinical insight, when the reservoir bag flattens, the lungs follow. A deflating bag means a starving airway. Call for respiratory help before the client's breath runs out. And finally, moving forward to reinforce this learning with a crucial exam reminder. Now for the Stancoast High-Yield NCLEX Pearl, the reservoir bag should always remain at least 1/3 full during inspiration. If it deflates, increase the oxygen flow rate or seek immediate assistance. Partial rebreather masks deliver 40 to 70% oxygen at flow rates of 6 to 10 liters per minute. Never allow the bag to collapse, as this increases carbon dioxide rebreathing and the risk of respiratory acidosis. Remember also that full rebreather masks differ because they include one-way valves that prevent rebreathing any exhaled air, thus delivering up to 100% oxygen. Above all, continuous monitoring and prompt reporting of equipment malfunction can make the difference between recovery and respiratory failure. Let us smoothly transition into this next advanced level NCLEX-style question that deepens your understanding of oxygen therapy and respiratory complications. A nurse is caring for a client who has been receiving oxygen therapy at a concentration greater than 50% for more than 48 hours. The nurse understands that prolonged exposure to high oxygen concentrations can lead to oxygen toxicity. Now, the question is, which of the following clinical manifestations would most likely indicate the early development of oxygen toxicity? You may select all that apply. Here are the options. A. Non-productive cough. B. Nausea. C. Hyperventilation. D. Headache. E. Substernal chest pain. F. Nasal stuffiness. The correct answers are A. Non-productive cough. B. Nausea. D. Headache. E. Substernal chest pain. And F. Nasal stuffiness. Now, let us explore the expanded advanced rationale behind this clinical scenario. When oxygen concentrations greater than 50% are administered for more than 48 hours, the risk of oxygen toxicity significantly increases. This occurs because excessive oxygen levels generate harmful reactive oxygen species, commonly known as free radicals, such as superoxide and hydrogen peroxide. These free radicals cause oxidative injury to the alveolar capillary membrane, resulting in diffuse alveolar damage, pulmonary edema, and reduced lung compliance. One of the earliest and most sensitive warning signs of this condition is a non-productive cough caused by irritation and inflammation of the tracheobronchial mucosa. As the toxicity progresses, clients may develop substernal chest pain, which reflects increasing tracheal inflammation and lung stiffness due to oxygen-induced damage. In addition, nasal stuffiness and headache often appear as early manifestations. These occur because of mucosal congestion and cerebral vasodilation associated with excessive oxygen tension. Nausea is another early systemic symptom that reflects the central nervous system's response to oxygen toxicity. If these warning signs are missed, the client may progress to more severe symptoms such as dyspnea, hypoventilation, pulmonary infiltrates, and fatigue, resembling acute respiratory distress syndrome (ARDS). On the other hand, hyperventilation should not be mistaken as a symptom of oxygen toxicity. It is more commonly linked to hypoxemia, anxiety, or metabolic acidosis. In oxygen toxicity, the opposite effect, hypoventilation, occurs later due to central respiratory depression and carbon dioxide retention. Therefore, early recognition of these subtle signs is crucial because oxygen toxicity is both preventable and reversible when detected promptly. The nurse's main responsibility is to titrate the oxygen concentration to the lowest level required to maintain adequate oxygen saturation, typically between 90 and 94%. The nurse should also employ positive end-expiratory pressure, PEEP, to enhance oxygenation without increasing the fraction of inspired oxygen, FiO2, and continuously monitor for early pulmonary changes, such as crackles, reduced lung compliance, or increasing work of breathing. Transitioning into the Stancoast clinical insight. When the lungs breathe too much of a good thing, they begin to burn from within. A persistent dry cough in a high FiO2 patient is not just irritation. It is an SOS from the alveoli, signaling impending oxidative injury. Now for the Stancoast high-yield NCLEX Pearl. Oxygen toxicity generally develops when FiO2 exceeds 50% for longer than 48 hours. Early signs include non-productive cough, substernal chest pain, nasal congestion, sore throat, and headache. Late signs involve hypoventilation, fatigue, pulmonary infiltrates, and decreased lung compliance. To prevent this complication, always use the lowest effective FiO2, apply PEEP, and monitor arterial blood gases, ABGS, and respiratory status regularly. Yo, future RN, hold up!
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us seamlessly move into this next high-stakes NCLEX-style scenario that truly tests both your mathematical accuracy and clinical judgment under pressure. A nurse is preparing to administer epinephrine to a client experiencing a severe anaphylactic reaction. The healthcare provider prescribes 0.1 milligram of epinephrine subcutaneously. The vial label reads epinephrine 1 to 1,000, which means there is 1 gram of epinephrine in 1,000 milliliters of solution. Based on this information, what volume should the nurse draw up to deliver the prescribed dose safely and effectively? Here are the options. A. 0.001 milliliter. B. 0.1 milliliter. C. 1 milliliter. D. 10 milliliters. Correct answer, B. 0.1 milliliter. Now, transitioning into the detailed rationale, let us understand the logic behind this calculation. The label 1 to 1,000 represents a concentration of 1 gram, or 1,000 milligrams, in 1,000 milliliters, meaning there is 1 milligram per milliliter. The prescribed dose is 0.1 milligram, so using the standard dosage formula, desired dose divided by concentration on hand, we have 0.1 milligram divided by 1 milligram per milliliter equals 0.1 milliliter. Therefore, the nurse must accurately draw up 0.1 milliliter of the solution to ensure the client receives the exact therapeutic amount. Moving from calculation to clinical understanding, epinephrine acts as a potent sympathomimetic, adrenergic agonist that rapidly reverses the pathophysiologic mechanisms of anaphylaxis. By stimulating both alpha and beta receptors, it causes vasoconstriction, reduces mucosal edema, enhances bronchodilation, and increases cardiac output, all of which stabilize blood pressure, relieve airway obstruction, and prevent vascular collapse. The subcutaneous or intramuscular route ensures fast absorption, making precise dosing and timing critical to survival. Now, shifting our attention to medication safety, note that using the correct concentration is a life-saving detail. The 1 to 1,000 solution, 1 milligram per milliliter, is intended for subcutaneous or intramuscular use during anaphylaxis, whereas the 1 to 10,000 solution, 0.1 milligram per milliliter, is reserved for intravenous use during cardiac arrest. Confusing these concentrations could cause catastrophic overdose or underdose, resulting in either cardiac arrhythmias and hypertensive crisis or ineffective resuscitation. Let us now evaluate why the other options are incorrect. To begin with, Option A, 0.001 milliliter, would deliver only 0.001 milligram, a dose far too small to reverse anaphylaxis. Administering such an insufficient dose could lead to worsening airway edema and circulatory failure. Next, option C, 1 milliliter, corresponds to 1 milligram, which is 10 times higher than ordered. Such an overdose could precipitate ventricular arrhythmias, severe hypertension, or cardiac arrest. Finally, option D, 10 milliliters, equals 10 milligrams, an amount that would be lethal in most cases, reflecting a grave calculation error from failing to cross-verify the drug concentration before administration. Transitioning into the Stancoast clinical insight: before emergencies strike, calm precision saves lives. A nurse's deliberate attention to decimal placement and concentration labels transforms panic into protection. Because in pharmacology, one misplaced zero can make all the difference. Now for the Stancoast High-Yield NCLEX Pearl. Remember this golden ratio. Epinephrine 1 to 1,000 equals 1 milligram per milliliter, used subcutaneously or intramuscularly for anaphylaxis, while epinephrine 1 to 10,000 equals 0.1 milligram per milliliter, used intravenously for cardiac arrest. Always verify the route, concentration, and client's condition before administration. Typical adult doses for anaphylaxis range from 0.3 to 0.5 milligram, 0.3 to 0.5 milliliter of the 1 to 1,000 solution. Though smaller doses such as 0.1 milligram may be prescribed for mild or pediatric cases. Never round decimals in potent medications. Precision protects your patient every single time. Let us now move forward into this next high-stakes NCLEX-style clinical question that beautifully combines therapeutic communication with acute respiratory care. A 32-year-old client with a history of moderate persistent asthma is brought to the emergency department, experiencing acute shortness of breath, audible wheezing, and visible anxiety. The client is sitting upright, using accessory muscles for breathing, and repeatedly says, "I cannot get enough air." The nurse initiates prescribed bronchodilator therapy and positions the client in high Fowler's position. Now the question arises: which nursing action is most effective in reducing the client's anxiety during this acute asthma attack? Here are the options to consider carefully. Option A suggests closing the door to the examination room to eliminate external distractions. Option B advises remaining within the client's view and speaking in a calm, reassuring manner. Option C proposes pulling the bedside privacy curtain to give the client a sense of privacy. Option D recommends notifying the client once the respiratory therapist arrives to continue treatment. The correct answer is option B. Remain within the client's view and speak in a calm, reassuring manner. Let us now explore the advanced expanded rationale behind this choice. During an asthma attack, clients often experience overwhelming anxiety caused by air hunger, hypoxemia, and the terrifying sensation of suffocation. By remaining close to the client, maintaining steady eye contact, and speaking in a calm, supportive tone, the nurse provides immediate psychological safety. This therapeutic presence directly reduces panic and helps the client focus on controlled breathing. It also communicates that the nurse is in control of the situation and that help is at hand, an essential intervention to prevent anxiety-induced worsening of bronchospasm. When emotional distress rises, catecholamine levels surge, tightening the airways further. Thus, the nurse's calm demeanor helps break this physiological and emotional feedback loop, optimizing the effect of bronchodilators and oxygen therapy. From a physiological standpoint, anxiety triggers the sympathetic nervous system, increasing heart rate, respiratory rate, and oxygen demand, all of which worsen respiratory distress. From a psychological perspective, reassurance and presence restore the client's sense of control, decrease fear, and promote cooperation with inhalation or nebulization treatments. This makes the nurse's calm and visible presence a therapeutic measure in itself, not just an emotional comfort. Moving on to why the other options are not appropriate, option A, closing the door to the examination room, might seem to reduce external noise, but can instead make the environment feel closed off and suffocating. Clients in acute respiratory distress often need open space and immediate access to help, not isolation. Option C, pulling the bedside privacy curtain, may unintentionally increase feelings of being trapped or alone, worsening anxiety rather than soothing it. Privacy is secondary to reassurance during respiratory crises. Option D, notifying the client when the respiratory therapist arrives, is helpful for communication, but does not meet the immediate need for emotional support. The client requires real-time presence and calm reassurance now, not later. Transitionally stepping into the Stancoast clinical insight, before pharmacologic interventions take effect, the nurse's calm and compassionate presence becomes the first line of therapy. Emotional stability from the caregiver translates into physiologic stability for the client. When a nurse models slow, steady breathing and offers gentle reassurance, it helps the client's breathing pattern stabilize and prevents panic-induced worsening of bronchospasm. And now, flowing into the Stancoast High-Yield NCLEX Pearl, remember that anxiety and hypoxemia amplify each other in a dangerous spiral. Anxiety increases respiratory workload, worsening dyspnea, while hypoxemia intensifies restlessness and fear. The nursing priority is clear: stay with the client, maintain airway patency, use calm communication, and guide slow, controlled breathing. Presence itself is a powerful intervention. Presence is medicine. A reassuring nurse's calm tone can physiologically ease distress before any medication begins to work. Let us now shift our focus to an advanced-level NCLEX-style question that emphasizes both client education and mastery of step-by-step technique. Imagine a nurse is reinforcing discharge teaching to a client who has just been diagnosed with moderate persistent asthma. The physician has prescribed daily home monitoring, using a peak flow meter, to evaluate airway function. The nurse explains that consistent use of this device allows early detection of airflow limitation and guides medication adjustments before symptoms worsen. Now the critical question arises: which sequence of actions should the nurse instruct the client to follow for correct use of the peak flow meter? Here are the options for you to consider carefully. First, the client should record the highest reading after 3 attempts. Next, slide the marker to 0. Then, blow out as fast as you can. After that, take a deep breath. Another step is to put the mouthpiece of the flow meter into your mouth. And finally, empty all of the air from your lungs. Correct sequence: 6 to 2 to 5 to 4 to 3 to 1. Moving forward into the rationale, it is essential to understand that peak flow monitoring is a cornerstone of self-management in asthma care because it provides measurable data about airway obstruction even before symptoms like wheezing or breathlessness appear. The first step, emptying all of the air from the lungs, ensures that the lungs start from their baseline capacity so that the next inhalation reflects true total inspiratory effort. Following that, the client must slide the marker or arrow to 0, a key step that calibrates the device by clearing any residual data from previous readings, ensuring that the new measurement is accurate and valid. Next, the client should place the mouthpiece into the mouth and seal the lips tightly around it. This prevents air from leaking out and directs the full force of exhalation through the flow meter. Then, take a deep breath in until the lungs are completely full, maximizing the air available for forceful exhalation. After that, blow out as hard and as fast as possible in one continuous breath. This step determines the peak expiratory flow rate, PEFR, which reflects how quickly the lungs can expel air, a direct indicator of bronchoconstriction or airway narrowing. Finally, because effort variability can influence the results, the client should record the highest of 3 attempts, as this best represents true pulmonary function. Transitioning into the educational aspect, the nurse must teach that these readings should always be compared against the client's personal best value, not a standard population chart. A decrease of 20% or more from the baseline signals uncontrolled asthma or an impending exacerbation, demanding prompt intervention or medication adjustment. Now, moving deeper into clinical reasoning, let us connect this with the Stancoast clinical insight. When teaching clients about asthma self-management, stress that declining peak flow readings often occur before physical symptoms develop. This early warning allows for timely use of rescue bronchodilators or medical review. Empowering clients with this proactive monitoring strategy shifts asthma management from emergency reaction to preventive control, an essential skill in long-term respiratory wellness. Building upon that key idea, let us transition toward the Stancoast High-Yield NCLEX Pearl for practical exam mastery. Always remind clients to maintain a peak flow diary and utilize color-coded zones for clarity. Green zone, 80 to 100% of personal best. Asthma is well controlled. Continue current medications. Yellow zone, 50 to 79%. Caution, use prescribed reliever and reassess triggers or medication plans. Red zone, below 50%. Medical emergency, use rescue inhaler immediately and seek healthcare assistance. Additionally, instruct clients to clean the mouthpiece regularly, avoid moisture inside the device, and perform measurements consistently, preferably morning and evening, for accurate trend tracking and optimal asthma control.